Hi, I'm Devin Conway, and this is another episode of Multiple Sclerosis Highlights, Report and Best Practices, Clinical Highlights from the 2015 ECTRIMS meeting. And today we'll actually be talking about Neuromyelitis Optica, Advances in Diagnosis and Treatment. The first abstract that I wanted to highlight is titled Alemtuzumab Use in Neuromyelitis Optica, a brief case series. So as we know, alemtuzumab was recently approved for the treatment of MS, and it depletes lymphocytes. And rituximab is known to have benefit in neuromyelitis optica by depleting B cells, so it stands to reason that alemtuzumab might also be beneficial in neuromyelitis optica. So these authors undertook a retrospective case series of individuals who got alemtuzumab, but it turns out that they do meet the revised criteria for NMO. And the first patient was a 31-year-old female who had experienced 2 episodes of myelitis and tested positive for the NMO antibody. She got 1 standard course of alemtuzumab over 5 days, but then over the next year and a half, she had 4 additional episodes of myelitis and now cannot walk unaided. She did later become relapse-free after being started on a combination regimen of rituximab and mycophenolate mofetil. The second case was a 41-year-old woman who had experienced recurrent myelitis and recurrent bilateral optic neuritis, but she did test negative for NMO antibodies. So this patient received 3 courses of alemtuzumab, each 1 year apart, but continued to have multiple relapses. She was eventually transitioned to rituximab, but this was also of no benefit, and she ended up dying at age 51. And the final case was a 9-year-old girl who had presented with protracted vomiting and bilateral optic neuritis. This was from a couple decades ago, and the NMO assay was not yet available at that time, so it's unclear if she was positive or negative. But this patient had been treated with intense immunosuppression but continued to have relapses, so she was eventually given 2 courses of alemtuzumab, but this was of no benefit, and she continued having relapses. She eventually developed blindness and became wheelchair-bound before dying at age 18, 9 years after she presented. So this is obviously a rather limited experience, but based on this, alemtuzumab appears ineffective for the treatment of NMO, and this probably would not encourage a pilot study of that drug for NMO patients. The next abstract that I'd like to highlight is entitled Autologous Hematopoetic Stem Cell Transplant in Neuromyelitis Optica. And this is actually an update. I presented this study last year in MS Highlights, but they have a little bit more data now. So it is a clinical trial with key inclusion criteria of a diagnosis of NMO, age 18 to 65, and they had to have experienced some breakthrough disease on an NMO therapy over the last year, with a total of 2 relapses in the last 2 years. And they also had some exclusion criteria, basically illnesses or cancer that might compromise their ability to complete the study or their safety in the study, or any significant cardiopulmonary disease. The primary outcome in this study will be the proportion of individuals who are relapse-free at 3 and 5 years, but they also have some specified secondary outcomes, including the number of NMO relapses requiring rescue therapy, time to the first relapse after the stem cell transplant, and finally, time to a 1-step increase in the EDSS scale. So prior to the stem cell transplant, these patients do receive a conditioning regimen that includes 4 cycles of cyclophosphamide and 1 dose of rituximab. The sample size now is at 3 patients, although they're planning a total of 10. and the 3 in the study have been followed for 4 years, 3 years, and a year and a half. And looking at the annualized relapse rate among these patients so far, the first patient experienced 5 relapses in the year before transplant, and in the 4 years after transplant has had no relapses. The second patient had 4 relapses in the year before transplant, and now 3 years later has had 1 relapse. And the third patient had 1 relapse in the year before transplant and has had 1 relapse in the 18 months since transplant, although this relapse is somewhat questionable as it involved only some pain in the torso with no actual change in the EDSS or the functional system score. So at this point, the results remain encouraging. The study does have some limitations, including that it's uncontrolled and has a small sample size, but that is to be expected from a pilot study. And there is also the possibility that some of the benefit might be related to the rituximab cyclophosphamide conditioning regimen, but some of these patients are getting fairly far out, including patient 1, who's now 4 years out from receiving that conditioning regimen and still has not had any relapses off of therapy. So we'll see if they have more information for us next year. The third abstract I'd like to talk about is called Antibody to myelin oligodendrocyte glycoprotein in adults with inflammatory demyelinating disorders of the CNS. This study was of 270 patients with CNS inflammatory demyelinating disease and 72 controls with non-inflammatory CNS disease like brain tumors, for instance. And the serum of all these patients was tested for antibodies to aquaporin 4 and to MOG using cell-based assays. It turns out that 17 of the patients tested positive for anti-MOG antibodies and 49 tested positive for anti-aquaporin 4 antibodies. The authors then worked on classifying the phenotypes of these individuals, and it turns out that none of the patients who had met criteria for NMO tested positive for the anti-MOG antibodies. Optic neuritis was more common in the anti-MOG group, occurring at 0.57 times per year versus 0.1 times per year in the aquaporin 4 group. But transverse myelitis was more common in the aquaporin 4 group, occurring 0.4 times per year versus 0.07 times per year in the MOG group. And both of those comparisons for optic neuritis and transverse myelitis were significant. Brain MRI abnormalities were more common in the aquaporin 4 group at 58.3% versus 29% in the MOG group, although that was not significantly different. And perineural optic nerve enhancement on MRI was only seen in the MOG group. More aquaporin 4 patients got immunosuppression than MOG patients did, 87.8% versus 23.5%, which might have influenced the results somewhat. And in terms of reaching an EDSS of 6 or greater at final follow-up, that was greater for the aquaporin 4 group at 10.2% than the MOG group at 5.9%. But we should note that the aquaporin 4 group had longer follow-up times than the MOG group did, so they had more opportunity to reach an EDSS of 6 or higher. So based on these results, MOG does seem to have a separate phenotype from anti-aquaporin 4 with more optic nerve involvement, less spinal cord involvement, and possibly better outcomes, although we need to see more data to definitively conclude that. The next study I'd like to talk about was called Tobacco Smoking and Severity of Neuromyelitis Optica. So we're all familiar with the fact that smoking puts one at higher risk for MS, and that MS patients who smoke reach disability milestones faster than non-smokers do. but the impact of smoking on neuromyelitis optica has not been well characterized to this point. So the authors undertook a 4-center retrospective study in 4 different countries of 139 patients with NMO or NMO spectrum disorder. And the patients in the study were classified as either never smokers, former smokers, or current smokers based on interviews or questionnaires. And the clinical data in terms of their disease course was obtained through chart review. So the authors found that current smokers had a higher total number of relapses at 8.3 than never smokers at 5.5 or former smokers at 5.1, and both of those comparisons were significant. They also found that the percentage of relapses that were severe were higher in current smokers at 73.3% than in never smokers at 39.2% or former smokers at 48.6%. Again, both comparisons being significant. And finally, they did find that the EDSS score was positively correlated with the number of pack years and with the total duration of smoking. So based on these results, smoking does appear to adversely affect NMO, similar to how it does in MS, although there are a couple of characteristics that possibly could have confounded this study. For instance, the authors did not report on follow-up time, and when you're talking about total relapses, if one group had longer follow-up than the other, that could obviously impact the result. Or it's a similar situation if one group had longer disease durations. So we'll have to wait for the paper to come out from this study, which will hopefully have a little bit more data for us. And the final abstract that I wanted to highlight was called "Do Vaccinations Trigger Relapses in Neuromyelitis Optica?" So whenever you give vaccinations in autoimmune diseases, there is always some concern because of the fact that vaccinations are designed to trigger the immune system, and the possibility that triggering the immune system might also trigger a relapse. So these authors undertook a retrospective study of 90 NMO patients across 3 centers who had a median disease duration of 6.3 years. And it was found that these patients had received 208 vaccinations and experienced a total of 326 relapses. Relapses occurring within 30 days of a vaccine were compared to relapses occurring within 30 days of any random date. And the way they did this was they used a statistical technique in which they sampled 30-day periods 2,000 times out of the data from these patients, and they counted the number of relapses occurring. And what they found were that the number of relapses occurring within 30 days of a vaccine was 7. Based on their statistical model, for a probability of less than 5% of observing this by chance, they would have had to have seen 9 or more relapses within 30 days of a vaccine. So this suggests that vaccines do not trigger relapses in NMO patients. And as it turns out, the annualized relapse rate among vaccinated patients was lower at 0.40 than among unvaccinated patients at 0.59, and this was a significant difference. So from this study, we can take away that there was no significant difference in the number of relapses seen within 30 days of a vaccine versus within 30 days of a random date. And in fact, vaccines might have an overall protective effect given that there was a lower annualized relapse rate among those patients receiving vaccines. And one thought for why that might be could be the possibility that vaccinated patients are having fewer infections, and hence because infections are thought to perhaps trigger relapses, that might be why they had fewer relapses. So that concludes this edition of MS Highlights. I'd like to thank you for your attention, and have a good day.